Yes, good. So this is our MCH, our Mother and Child Health Team. We have our staff here. They just introduce themselves, and then
You're welcome. This is our MCH department. I'm Iska Almondi. I'm the reproductive health coordinator. Mata works here. She is the research. Good morning. Good morning. Your name is Mark Mbanga, working in MCH.
yes, and I have my colleague Ruth. Also, we are working here.
Okay, thank you. So, don't worry, we are just taking videos of the services that we offer. Mimi ni Dr. Nyalita and Waziri hapa Nairobi County. So we're just going to take a picture. At least there's a lot more people to seek facilities. That there's medicine, there are very qualified doctors and nurses and all the healthcare workers, and that you can actually get quality services, okay, at affordable cost.
Child health clinic with the family planning. So what basically happens is that we are open Monday to Monday, because on Saturday and Sunday we also have to vaccinate the children who've been delivered, back polio and BCG, so that we don't have issues of dropouts or defaulters. So we basically work from Monday to Monday. So today we have a special day, and our special day is that we have the gynae clinic. So every Wednesday we have about 40 to 50 patients being seen, and these are clients who have issues concerning gynecology. It could be uterine fibroids, it could be infertility and all that. So every Wednesday we have about 30 to 50 patients we see, but apart from that we also see our normal clients. What happens is that we don't give them a return date of Wednesday, but whoever comes does not miss the services. So as you're seated, they're seated here waiting, these are clients that we are doing the baseline observations, so that when the consultants come in the next 10-20 minutes, then they will be able to be seen. So basically that is what we have here, our triage session. Just beside us we have the registry, and in the registry, what happens in the registry is that we register all our clients who come in. That is where Linda Mama is registered. And apart from the Linda Mama, we also have Linda Toto. That Linda Mama works for the mother, and when the baby is admitted to the newborn unit, then now the Linda Mama, we convert it to Linda Toto, so that it's also able to cover the baby. So Linda Mama is about services, the clients being registered. After being registered, it means that they will not pay a single cent. The national government takes care of their payments. But the client who is coming in for a normal delivery will be paid for 5,000, and the client who is coming for cesarean section will pay 10,000 shillings. Yes, it will be catered for. So that is what Linda Mama immunization, or they are going home. So the ones coming in for immunization get the immunization in this room. Apart from the immunization, we give tetanus vaccine, we give supplementation IFAS, and we do further counseling. So basically it is a head-to-toe examination for the mother, so that we are able to know at what stage the mother is, and to identify any risk factors that there could be. And then we take action. So that is what happens in this room. Because today is Wednesday and we have the gynae clinic, our clients are few for antenatal, because we don't give them a return date of today, because we have the other clinic. However, those who come, we usually attend to them first, so that we can continue with the gynae clinic. So this is PMTCT room, prevention of mother to child transmission, that we will counsel all our clients who come in. We will test them for HIV. If they are positive, then this is the room that they are served in. So once they are positive, then we start them on treatment. Reason for starting them on treatment is that we are trying to prevent infection to the baby. Yes. So PMTCT room, we usually have counselors in this room. We have the medications in this room, and we take samples from this room. So basically that is what happens here, that all mothers who are pregnant are counseled and tested. That is the first time they come, they are counseled and tested. If you are negative, we cancel and test you after another 3 months. If you are positive, then this is the room that handles that. They will be put on treatment from there and then. Reason, so that we are able to prevent transmission to the baby. And once they come here, we are also able to give the mother the baby's dosage that they will give immediately the baby is born. And that one is usually done during the first visit the mother comes. Why do we do that? We do that because we are not sure this mother would come again to this facility or would go back to a hospital. So the essence of her being ready with the baby's medication anytime the baby is born. So basically, that is what PMTCT is about. All the methods available, that we have pills, we have implants, we have the natural methods like the psycho-bead, we are able to see there. Then we have of looking at the cervix to know the situation of the cervix and the status of the cervix, or we will take a pap smear. Once we take a pap smear, it is on a slide, then our pathologist in the laboratory is able to read and give us a report on the status of the cervix. So depending on what we get once we do the cancer screening, then we know what action to take. Is this a client that would want to refer to the gynecologist to see in theater to do an EUA, that is examination under anesthesia, to collect a biopsy, or is this a client that we would simply treat with thermoablation or what do we call it? A thermoablation or colposcopy for further investigations. So that is basically what happens here, that we do cancer screening, both the via villi and pap smear, and then the other thing that we do here, family planning. That all our mothers at risk are able to be seen from Monday to Friday. Working in this department, MCH Clinic. Basically what we do here is to handle the mothers, the babies, and occasionally the fathers, because they accompany the mothers to the clinic. So what happens in this clinic as the mothers come in? They come in for several activities inside here. They come in to seek several services. That a client is coming with a baby, and as they come in with the baby is coming in for immunization. And the baby will get the immunization, the baby will have growth monitoring done, the baby will have counseling, the mother will have counseling done, and then there could be issues of supplementation, especially if the baby has malnutrition or overnutrition. So that is basically what happens here as the mothers come in. Apart from the mothers coming in with the babies, we have a mother who will walk in alone. The mother would be coming in for antenatal care, would be coming in for gynecological care, or the mother would be coming in for family planning. When these clients come in at that particular point, then you are able to triage the client and get to know what is this client coming for. Is this client coming for antenatal care? Our antenatal care runs from Monday to Friday, 8 to 5. So if a mother is coming in for that, our first step is usually to take the baseline observations, the baseline anthropometrics, and then we send the client for antenatal care profile, so that we are able to get more that is happening to this client. Then we start following up this client. The same clients would be coming for family planning. When you get such a client, the client could be coming in to get a method, or the client wants a method removed. And most of the time you find out that, why do you want to stop family planning? Most of the time you find that this is a client who wants to conceive. When that happens, then it means again that you have to put this client in the preconception care clinic and start working with this client until this client delivers. So the essence of doing our triage here, it is basically free of charge. What happens is that they will only pay 1,300 for the antenatal care profile. Then the rest of the services are free of charge. They will register for Linda Mama, and the Linda Mama caters for the mother in delivery, either CS or normal delivery. So once we work with them like that, we work with them in.
So this is our eye units. So I can just go in 9.
This is our eye unit where we offer eye care services. We have three ophthalmologists and we also have the other cadres, the ophthalmic clinical officers and ophthalmic cadres. We see an average of 40 patients per day. This is our waiting area. When the patients come, they are tried. How the trial is done for the eye, taking your vision, and then you first register, and then you wait. Vision is taken, and then after that you're directed to the consultation rooms. Ophthalmologist, Dr. Nyalita, Waziri. It's okay. Different gadgets which you use to examine the patients. We also do, apart from the medical treatment,
patients, and the patients we usually admit for admission for surgeries, cataract surgeries on Tuesdays, that is yesterday. We admit them here, we take their observations and the history taken and the
both surface eye surgeries and intraocular surgeries. So it's important that Kenyans know cataract surgeries are available at Mbagathi.
And what is the fee?
The fee is 7,500
for the NHIF
for cash paying patients, but if you have NHIF, it fully covers for the surgery and the inpatient care. Surgery patients, they are admitted a day before, surgeries are done the next day, and then they are discharged one day after surgery. Department.
And then morning, my name, my late super said, I'm Dr. Anastacia. I'm a family physician, but I'm the acting HOD, outpatient casualty for Mbagathi. We have a unit of 8 beds, an 8-bed unit. The first floor we have monitors that are attached or mounted on the wall, and we have 2 portable ones that help us in monitoring of our clients. And on the other side, we have piped oxygen for all the 8 beds. It's a small unit, but we are able to take care of our emergency.
This is my second event for the day.
Outside, we have an isolation area we set up for the patients who have acute diarrhea, and we see them before we stabilize them, before we transfer them to the isolation unit. So this is where we see our patients.
And then if you're
we normally have our team is just made up of 6 medical officers. That is for the emergency side. And we have a team of 15 nurses, a total of 15 nurses. But on a daily basis, we have students rotating with us who are mentored by our senior nurses. So basically what we do, we got revamped recently, and from that we have improved patient monitoring from the machines that you've seen on the wall. The piped oxygen has enabled us to be able to attend to our clients while on the bedside without having to carry our cylinders along. And we're able to retain our patients here until they are a bit stable to be taken to the ward, until the bed space is available. Yes. This is one of the portable monitors. We have a fridge that serves as storing the drugs that can have to be maintained, refrigerated. This is the emergency room, basically where we put the very sick patients, the unstable ones, we put them here. The next room, yes. Any concerns, then I can address them for our patients. Yeah. You don't have to keep patients for the moment. You are visiting alone? You brought good luck for them. That help us to man 2 patients at a go. And basically what happens there is stitching, dressing of the patient, and before we transition them, especially acute ones, we transfer them to theater. And we also have an orthopedic trauma unit, which is also, people normally refer it as a plaster room. This is where orthopedic trauma. So you cannot retain all the patients. You cannot view them all the way from the inside. So we see them from here. The big stable ones, the other consultants. Then we have an HOD office that is at the extreme end. That is where the office where I sit, which mostly in an emergency setup you rarely see. We normally do our trial right here. We do a and then we transfer the acute ones inside and the rest here where our patients are. Then right inside you'll have 2 consultation rooms where the clinicians and the doctors sit to view the patients. So this is basically now the emergency side. That's the resuscitator for the very small babies. We have the oxygen cylinder. On this side we have not managed to get pumped oxygen, but we are hopeful. It's coming.
Based on health initiative, and then adapted to the oxygen tank, the liquid oxygen tank, the testing will be done, and then a bus that will be packed with all the...
That will be amazing. Clients, the very sick ones that require fluids resuscitation, and we have different rooms. There's another room on the inside. Hello. Hi. How are you? We have a
So afadhali bila ugonjwa.
Oh yeah, because you can be sued. So this unit normally has 2 dentists. Consult for privacy. Yeah.
Laboratory Mbagathi Hospital. It's an accredited lab. That is, we are updated to the international levels. So our tests, our results are internationally accredited. So when you come here, you are assured of quality and reliable results. You don't have to worry, you don't have to go and look for Nairobi Hospital, you don't have to go to any other hospital. Our results are accredited. So this is our inside here, but we don't leave it open. We store our chemistry reagents. We have the backups. We have Eden as a backup and Urit as a backup.
Yeah, and here we are running to receive. This is the environment, the main analyzer for doing. You receive LFT, lipid profile, bone chemistry, CSF bone biochemistry, and also we have another analyzer here for electrolytes, that is sodium, potassium, and sulfate, that is able to do thyroid tests, hormonal profile, cardiac markers, PSA, and many more.
Good morning.
Good morning.
Yes, this is microbiology. We do cultures of all the samples, stool, urine, CSF, blood culture. This is Vitec machine. Automated machine is able to do identification and sensitivity. We also have blood culture machine. This is our blood culture machine. We're able to do all the blood cultures using blood alert. And then we have TNS machine for doing TB.
Yeah. H. pylori, Salmonella.
We are a small busy unit. This unit was set up as a stopgap measure because originally the newborn unit was on the first floor of the maternity block, but out of circumstances we moved because there needed to be some major repairs, and then COVID happened and all that, so we were hosted on the block 4. This is the lower building. But since we reopened our maternities, our numbers shot up drastically. So for a unit that's designed to hold about 30 babies, we accommodate upwards of 70 to 80 babies. Wow. And that becomes a challenge. We have about 50-60% of our admissions are preterm babies. The rest being term but sick babies. We are level 5 facility, so we receive referrals from facilities, level 4, level 3, and even the small private facilities that feed to us. And so we are able to provide a modest level of care. Our biggest challenges right now are space, so we really need to move to a bigger space. We also are in the process of trying to set up ICU services because respiratory mobility is high on our list as cost for admission and also the leading cause of mortality. So we really need to set up our ICU services, and we are happy that finally at least there's repairs going on and we will be able to move to the newborn unit to the other side. We are very grateful for that.
We are hoping in the next 2 weeks.
Nice. Very good. Then we start ICU up here. So that, because one of the big challenges again we've had here is traffic control. See, this unit was not designed for newborn units. We don't have any order. It's a single room, yet we have babies we need to isolate. We need to grade care in terms of the very sick, the small ones, the big ones, none of which is possible here. So the other unit will really help us to classify babies and do not.
Hiyo mkitoka hapo mkwenda hii ndio embalming room. Na hii ni embalming table. Hiyo mashini imeharibika. Karibia tu.